Perfect, and we can go ahead to the next slide. So today's agenda will include introductions and announcements, a didactic presentation on initial hepatitis C treatment selection for adults by Dr. Clark Allen, an adult case presentation, and some closing remarks as well. First, some in-chat introductions as well as some brief announcements. Before we get started, I would like to ask everyone to take a second to introduce yourselves in the chat. Please be sure to include your name, your role, your organization, and whether or not this is your first ECHO session with us. Like I said, I feel like I see several new names, so we're very excited about that. So a few quick reminders while everybody's getting their names placed in the chat and introducing themselves. I do want to highlight that you, as you join the session, you may have noticed that it'll be required to sign in. So I need everyone, including our subject matter experts and our TDH team, to take about a minute or so to complete this sign-in sheet. You can utilize the QR code pictured on the left here, or the website, which will be placed into the chat. There, I see Lindsay put it in the chat. So this sign-in sheet is required for our accrediting body, and it's the only proof we will have of your attendance as far as they're concerned. So if you do not complete the sign-in sheet, you will not be eligible for the CE. And even if you don't want the CE, we still need you to complete the sign-in. So I'll give everyone about a minute to complete that. Again, you can use the QR code or the link in the chat. And as you're completing it, if you'll just give me a thumbs up to let us know that you have finished. And Dr. Chastain or Clove, if you're on the call and want to go over the other kind of sign in, that would be great.
Hey everybody, my name is Cody Chastain. I am a adult infectious disease physician. I'm one of the subject matter experts for the Project ECHO team. And I just want to highlight that Clove Tipton had just shared in the chat box as well a separate registration. We are representing the Southeast AIDS Education and Training Center, as well as the Tennessee AIDS Education and Training Center. And Clove, my participation and support for this team and for these events really are free. It's just that we are trying to make sure we represent the work that we do to the federal government based on some of our HRSA related funding. So if you are willing and if you are able, you can, in addition to this very important attendance tracking, which is absolutely necessary for the TDH team, if you are willing to additionally click on that Tennessee AETC link that was dropped in the chat box while you're listening and participating in the program, that would be appreciated. Thanks so much.
Thanks, Dr. Chastain. So I'm starting to see some thumbs up. So perfect, and we'll go over this again at the during the closing remarks as well. So please go ahead and turn on your video if you are willing. We'd love to see your face, and mute yourself unless you're speaking, but please feel free to come off of mute to ask any questions that you might have throughout the presentation. And Anastasia, did you notice that anybody joined by phone?
Nope.
Great. So as a quick reminder, please never discuss PHI and treat everyone with respect. Next slide. There are just a couple of events that we wanted to share with everyone. Next slide. The first is the Community Liver Alliance and National Viral Hepatitis Roundtable is co-hosting the Real World Solutions for Eliminating Viral Hepatitis C in PWID and Appalachia as a virtual summit. The virtual summit will be held on May 16th from noon until 12:30 p.m. Eastern Time. And you can register using the QR code or the link in the chat. The Sharing Harm Reduction Practices, or SHARP, is also having a virtual meeting. This is an annual gathering, and it will be on May 17th from 8:30 a.m. to 2:30 p.m. Central Time. So this event will feature regional speakers and panelists on a range of emerging harm reduction topics and best practices, including perinatal harm reduction, death by distro policy research, navigating the harm reduction funding landscape, and more information. So again, you can use the QR code to register, or the link has just been placed in the chat by Lindsay. So with that, I'm going to turn it over to Dr. Allen to provide our didactic for today. Dr. Allen, please make sure to say next slide when you're ready to advance. And if anyone would like to review the pre-treatment evaluation recommendations, then feel free to check out our recording from March 1st, which is on the Tennessee Project ECHO website, which we'll also place in the chat for you. So Dr. Allen?
Thank you for the introduction. Yeah, I was going to reference Dr. Chastain's initial lecture about over a month ago. Next slide. So we'll start out with hepatitis C treatment in adult patients for today. I have no financial disclosures or conflicts of interest to report for this lecture session. The goals of treatment. We want to cure patients of hepatitis C. That's the main goal. We want to prevent any further liver injury. The main way of how we conduct that is to draw a blood draw of hepatitis C viral load. We're looking for it not detected. It needs to be more than 12 weeks after the completion of treatment. So that's why we would like to know when they start and when they finish, and when to know when we can draw that final blood draw to know officially that we can say that they are cured. So SVR12, you'll hear us say it a lot. Sustained viral response 12 weeks after treatment, meaning that there is a not detected viral load of hepatitis C 12 weeks after the treatment course. The main things we are trying to prevent by treating and curing hepatitis C are liver complications, such as liver cirrhosis, end-stage liver disease, hepatocellular carcinoma, which is mainly what I like to tell my patients. Usually that's something that will draw their attention as something we're trying to prevent, as well as potentially needing liver transplant. So those are things of kind of long-term complications that can be associated with hepatitis C virus, and for the need for the treatment. Next slide. So there are, just like we talked about 2 weeks ago, there is a simplified treatment algorithm for adults. There's actually 2 of them, where there's only one for pediatrics. So we're going to talk about both of them, one more in detail than the other one. Next slide. They're both located on the Hepatitis C Guidelines website. I wanted to put both of them side by side. They look very similar, so I wanted to notate the differences. The one on the left is without cirrhosis, so you're going to see at the top how to distinguish between the two: without cirrhosis versus with compensated cirrhosis for the 2 simplified treatment algorithms. We will, for the purposes of time, we'll focus more on without cirrhosis for today. We'll cover more with compensated cirrhosis on a later session. Next slide. And you go on next slide. So for patients without cirrhosis, so we'll start with that one. Any adult who is over the age of 18, so anybody who's less than 18 would fall under the pediatric algorithm. Anybody older than 18 is indicated, who is not with cirrhosis, would be indicated for this algorithm, as long as they're at a greater than 1 year life expectancy. That's part of the guidelines as well. If they have a short life expectancy, treating of hepatitis C would not be one of the primary goals of a patient at that time in their life. So that's something to take into account as well. Any genotype is eligible during a simplified treatment algorithm. They cannot have cirrhosis, and that is defined by some type of fibrosis staging. So it will be either a FIB4, an APRI. Those are kind of the quicker options. There's also an elastography, a FibroScan, and then there's also a blood test called a FibroSure. So multiple different ways you can do staging of liver cirrhosis or fibrosis to know if there is cirrhosis present. They need to be treatment naive as well. Any prior treatment would automatically refer them to a specialist. So that includes peg interferon, ribavirin, or any other hepatitis C medication. Those would be referred to a specialist. So that kind of brings me to the next point. Things that are not eligible for simplified treatment algorithm: cirrhosis, if they have hepatocellular carcinoma, if they've already been on a treatment plan in the past, if they're co-infected with HIV or hepatitis B. And that will come into play with the labs in just a second. If they've already had a liver transplant, or if they're pregnant, those would be indications that they need to be referred to a specialist. So those are things to be kind of marking off on your checklist when you're evaluating a patient to see if they're eligible for the simplified treatment algorithm. Next slide. There are a couple key differences in the simplified treatment algorithm for compensated cirrhosis. Most of everything is the same. Of course, this one's going to be eligible if they have compensated cirrhosis, but they would not be eligible if they had decompensated cirrhosis, and that would be reason to refer those patients to a specialist at that point. Also, a key note to this one, some little extra: end-stage renal disease, so anybody less than 30 EGFR, so glomerular filtration rate. So one of those, trying to make sure you establish that if they have renal disease, you want to make sure that you refer those as well. Next slide. Now, I put pregnancy at the end of the criteria to refer to specialists because we wanted to make sure we address those patients specifically during this session. So next slide. So one of the main keys of this session is we want to establish when is a patient indicated if they are or thinking about becoming pregnant. Based on the guidelines, before pregnancy is preferred. That makes a better outcomes for the patient, as well as not putting the infant, the newborn, to be at risk of being infected with hepatitis C. So before is preferred. During is still up for debate. There are small studies out there that do show that there's safety in hepatitis C treatment during pregnancy, but we don't have large-scale studies just yet. So we're still waiting on information and guidelines for that. After pregnancy is also an option. We want to have a conversation with the mother, depending on breastfeeding and other type of factors, and that will flow into the next slide. So as far as monitoring during pregnancy, so this would be a patient who actively has hepatitis C, but we're not going to treat them. We still want to monitor their viral load. You will see changes in their viral load throughout pregnancy. You'll also see changes in their liver function test. Those are just things to monitor, not necessarily to always treat. You can treat a patient depending on patient-specific factors. You want to have a conversation with the physician and the patient if there's risk versus benefit of treating their hepatitis C during pregnancy. There also might be a question that come up later. I'm going to go ahead and answer it. What if a patient starts hepatitis C treatment and then becomes pregnant? That would be a case of to have just a case-by-case explanation with the physician to kind of talk through that and make sure everything's still safe and make sure everything's being monitored. The only time that I can think of that we definitely wanted to stop treatment, it would be outside the scope of this practice or session. But if a patient was on ribavirin, that would be a reason to stop treatment course because ribavirin is a kind of a adjunct agent in hepatitis C treatment, and it is also a teratogenic agent for infants. So we want to stop that treatment in that particular instance. Now, for patients who have already delivered their baby, we would want to counsel them on breastfeeding. It's not a contraindication specifically, except for these reasons listed. If they have cracks or damaged nipples, we want to, or they're in the context of HIV infection, we would want to hold off during those times. Also, if the woman is infected with hepatitis C, they want to be reevaluated after the potential for spontaneous clearance. There's a lot of different changes, and that's why I mentioned monitoring levels during pregnancy of the viral load. There can be times where there can be changes in the woman's body that they can spontaneously clear it after pregnancy is over, and that's something that you can kind of check a viral load after the fact just to see. Normally, in our practice, we will just go ahead and treat them and not kind of try to play the waiting game. We'd prefer just to go ahead and treat them instead of kind of waiting, because there's always a potential risk of being lost to care or something like that. So we try to just go ahead and treat them if they're ready to go from that standpoint after delivery of the baby. Next slide. So these are the kind of main factors that I take into account for each patient case. That includes pregnant patients, that includes everybody else. We want to make sure we're looking at their lab results first, looking at their hepatitis C viral load, knowing what their baseline viral load is, knowing what their genotype is, and also what their hepatitis B status is. We want to be checking that because there is that risk of reactivation when hepatitis C medications of a hepatitis B virus. So we want to know that as well. We also want to know if they're HIV co-infected. That can play a role in looking at drug interactions. And of course, we want to know if the patient is of childbearing age. We want to be checking a pregnancy test and counseling those patients on that issue. We also want to be looking at, from a lab's perspective, of their liver fibrosis. We want, like I mentioned earlier, the different types of lab tests, the APRI, the FIB4, the FibroScan, and the FibroSure, different modes of how you can check and stage a liver fibrosis to know if they're not cirrhotic or cirrhotic. And then if they do have cirrhosis, you want to be able to use the Child-Turcotte-Pugh score to determine if it's compensated or decompensated. And then that would let you decide which treatment algorithm, whether it be the simplified without cirrhosis or simplified with cirrhosis. So we want to be able to use all those different components to be able to stage the liver to know where we're at, to which algorithm to use. We also want to make sure we're doing a great medication reconciliation with each patient, because there are interactions out there with each hepatitis C medication. Specifically in the adult population, you'll see a lot of patients be on statins. Those are interactions with hepatitis C medications. We will talk more in detail at a future session on the specifics of which statins are preferred with which agent. Heartburn agents are as well. That includes antacids, that includes Pepcid, H2 blockers, that includes PPIs. All of those agents come into play. There are nuances to each one of those, and I usually navigate it by case by case basis with each patient. Seizure medications as well. There are some seizure medications that are okay, some that are not, and we'll discuss that further. HIV is also potential. There are some agents that do interact with hepatitis C medications, some do not, and we'll cover that more in detail. Anticoagulants and tuberculosis agents as well. So lots of different agents that do cause interactions, and we just want to be aware of those with each patient case. Insurance formularies can dictate sometimes which preferred agent on their medication list, and that can sometimes steer you to a specific agent. So we want to make sure we're looking at formularies before we start PAs, and that way we don't get denials, and then we don't have to do appeals or anything like that. Now, if we've gotten a point where we do have a need for something that's off formulary, we want to make sure we have all the clinical literature and evidence behind that specific case to be able to present to the insurance. We'll talk about that more in a later session as well. And then if all those things are lined up and we still don't have a clear-cut option between all those different factors, we can also put it up to the patient. And so if there's still options out there, we'll ask them what they prefer. Do they prefer a shorter course? Do they prefer the longer course that's maybe simpler with one pill? We'll let them make that choice at that time if there's no other drivers that are kind of directing to a specific agent. So lots of things to take into account with each patient case. Make sure you have your checklist of going through these things before you have a good, firm decision on what the treatment course would be indicated for that patient. Next slide. So there's the drug interaction resources. So this is what I use to make sure I'm checking for interactions, especially with new medications when I was familiar with, making sure that they're not interacting with a medication that I would like to select. I have a subscription to Lexicomp and Micromedics through my institution. If you don't have those subscriptions to those places, I like to refer patients to people to the left for the Liverpool interaction tester. That one's free. It's very simple to use. You just add your drug and then add which hepatitis C medication, and then it will pop up in the third column if there's a potential interaction or not. So all of these are very well utilized and very effective at telling you if you should steer clear of this potential interaction or it's okay to proceed. So definitely want to utilize these before starting any medication. Next slide. So now let's talk about the medications. So let's go to we can go ahead to the next slide. So now we've got to the main aspect of the course today. Now I wanted to highlight the two in green. These are the preferred agents on the simplified treatment algorithm. I wanted to also put a ledipasvir sofosbuvir on there, but main two agents that will be utilized in the simplified without cirrhosis and with compensated cirrhosis are gabapentinoid, pibrentasvir, trade name Mavorite, for 8 weeks, regardless of which algorithm it is, as well as sofosbuvir, velpatasvir, trade name Epclusa, for 12 weeks. Both of those are good to go for either treatment algorithm. I wanted to put on ledipasvir, sofosbuvir, trade name Harvoni, 8 to 12 weeks. It depends on certain factors, and we can talk about that just a little bit. For 8 weeks, it is preferred on a patient without cirrhosis. So that's one of the key factors. There's other ones involved, including co-infection with hepatitis B or HIV. Their viral load has to be less than 6 million. So that's kind of the kicker. That's not part of the simplified treatment algorithm. And then they also cannot, or they have to be treatment naive as well, and they can't have cirrhosis. So there's about 5 factors that go into if a patient is indicated for 8 weeks of Harvoni, otherwise they will be indicated for 12 weeks if any of those things are kind of ruled out. Next slide. So let's talk more in depth about glecaprevir preventosvir, trade name Mavyret. It is pangenotypic, genotypes 1 through 6, so it treats all of them. It is 3 tablets, it all at the same time. That's kind of the main counseling point. When I'm counseling patients, I want to make sure I'm saying it's once a day, it's 3 tablets, and it's got to be with food. I tell the patients it's better, it's correctly absorbed, and it's also reduces side effects taking it with food. So I give them 2 reasons to take it with food, so make sure you hammer that home. It is an 8-week course, whether they do not have cirrhosis or if they have compensated cirrhosis, 8-week course regardless. Side effects are very minimal, very well tolerated medication, headaches, maybe fatigue at most for this agent. Not really heard of any other side effects with Mavyret. If patients complain of other side effects, it's potentially something else within that patient case that might be causing those side effects. Next slide. The other main agent is sofosbuvir-velpatasvir, trade name Epclusa, also pangenotypic, which makes it easy from a perspective of not really requiring a genotype. The main reason to get a genotype is for insurance providers. They might require it. We also like to know at our clinic just for kind of recording purposes. This is a 1 tablet once a day, no regard to food, very simple. Some patients will like that aspect to not have 3 tablets. Some patients prefer to get it over with quick for the 8-week course. This is a 12-week course. There is no 8-week option with Epclusa. The side effects are very similar to the previous agent, headaches, fatigue, and there are GI issues that have been associated, maybe some nausea, upset stomach, maybe diarrhea in rare cases. I tell patients to take it with food if they are experiencing those GI side effects. There is a generic Epclusa available, so it would just have sofosbuvir-velpatasvir on the box. And some formularies will prefer the generics over the brand name. Next slide. Then I also wanted to cover limdipizvir, sofosbuvir, trade name Harvoni. It's only approved for genotypes 1, 4, 5, and 6. So you wouldn't need to do genotyping if you were going to consider Harvoni in a patient. It's very similar to Epclusa, 1 tablet once a day, no regard to food. We've already talked about the 8-week course for uncomplicated patients that includes no cirrhosis, treatment naive. They can't be co-infected with Hep C can't be co-infected with Hep B or HIV, viral less than 6 million. There is mainly, I would say, 12-week treatment course option if they don't meet those criteria. Common side effects, very similar to sofosbuvir-velpatasvir, headaches, fatigue, GI issues. There's also a generic Harvoni available. It kind of just depends on insurance formularies, whether that is preferred or not. And so I kind of just will go with what the insurance will prefer at that point and go from there. Next slide. So as far as once a patient gets on the medication, the most important thing you want to tell your patients is to take it every day, to not stop for any reason. Definitely reach out to the provider's office if you want to stop, and let's talk about it and go through those things. I just tell them, once you start the medication, you want to treat it like an antibiotic course. You want to complete the full course to give us the best chance of cure by the end of it. So just taking it every day is the most important thing to do, making sure they always take it with them. It's very expensive medication, which is why I like to follow them very closely and make sure I get all the refills to them, and also let them know if they go on a trip or go to the hospital, make sure they're taking their hepatitis C medication with them, because no one else will have a supply of it. So trying to make sure, just reinforce those ideas that this is their supply and their supply alone for the treatment course. Monitoring for drug interactions. Sometimes patients will start new medications or discontinue medications, making sure that you're going through a medication reconciliation every time you talk to them, making sure that they are still no issues with drug interactions while on the medication course. Monitoring for side effects and adverse effects. I want to always be asking them about what they're experiencing, and then that kind of goes along to kind of tell patients in the future, because real world side effects, it's easy, or it's more beneficial to be able to tell patients this is what other patients have experienced in the past, and then I can kind of relay that to future patients, because everybody's I wouldn't say everybody, but a lot of patients are very hesitant to want to start something new, and they feel like they're going to have side effects and they're not going to tolerate it. And I'm able to tell them, based on my patient population, these are the side effects that have occurred, and it only happens for a day or so. So it gives them kind of peace of mind to know that I have real world experience with the side effects, and not just reading it from the package insert. You also want to monitor for patients on diabetic medications. There's been shown that there can be hypoglycemia when patients are started on hepatitis C medication, as well as monitoring international normalized ratio, INR, for patients on warfarin. Those are also things to take into account for those patient populations. Make sure that they follow up with their primary care doctor accordingly during and on treatment. And then as far as the final thing, you want to make sure you're checking a viral load. Once, we prefer sometime during treatment, doesn't have to be required. And then of course we want to make sure we're following up at SVR12, sustained viral response, 12 weeks after treatment course, to check the viral load for cure. Next slide. I think that concludes my presentation for today.
Great. Thank you so much, Dr. Allen. Any questions for Dr. Allen? Feel free to come off mute and ask your question, or you can put it in the chat.
Is this where we present cases? I was told I could present a case and get a recommendation for treatment.
Yeah, that's a great question. So we do present cases. Typically, we try to schedule them ahead of time. That way we can create slides for them and then go over them. If there are specific questions that we can answer today, we're always happy to do that. We have lots of great people on the call. And so we can, answer what we are able, but we can put the link in the chat to submit your presentation or your request, and then we can get a date scheduled so that you can present your case in particular.
Okay, well, I was given this link for that purpose, and I'm not sure I was supposed to do something. I'm new to this. I'm sorry. Can you?
No, that's fine, because it's a great question, and we're always wanting to do sessions. So, Lindsay, if you want to, she just did. So there's a REDCap link that you can click on, and if you want to fill out as much information as you can about your client, it'll give us kind of some baseline information and help go into a little bit more information. If there's a particular question, though, you're always welcome to email us as well. If you need, a question answered more urgently, and we can see how we can help or get our subject matter experts to weigh in as well. But if there's a general question we can help with today, feel free to ask.
Okay.
Does that help?
I think it helps. I saw the link pop up, and so I'll pull it up and look at it.
Perfect. And Lindsay, if you don't mind dropping our email in the chat too, just in case it's needed for a question more quickly.
Thank you.
Any other questions for Dr. Allen about anything we talked about today? Otherwise, I'll get us started with some questions while we're waiting.
Mia, there is one question in the chat from Stephen Miller.
Okay.
The Harvoni generic, a great deal cheaper, ?
I would overall, yes. From a patient standpoint, I would say there's probably not much difference, because what I do know is that generic Harvoni does have a copay card. So even if there is a large copay, there are copay cards available for generic Epclusa and generic Harvoni. I could get it's called Asegua, is the kind of the company that kind of has partnered with to do the generic. So as far as from a patient perspective, don't expect there to be a difference. It probably will still be a $5 copay for commercial insurance plans. But from a purchasing standpoint, it probably is a great deal cheaper if you're purchasing it at wholesale pricing.
Thank you. Additional questions? Any questions or comments from our subject matter experts? Okay, so we talked about a lot of things that felt like today. So some questions that I have, how common is it, would you say, for hepatitis C to be transmitted during pregnancy or birth to the infant? Is that something that I know it's something that you mentioned we want to be thinking about and counseling on, but is it pretty common? What do you usually tell clients when you're counseling on this?
Yeah, so it's about, I think if I remember correctly from the guidelines, it's about 5% or 10% from vertical transmission. So there is a potential, but it's not something that's guaranteed like some other viruses. So it is something to take into account as to why we do want to treat them beforehand. If they're considering pregnancy, that would be great, but there is that risk, and we want to just have them follow up with their pediatrician afterwards if we know the mother is still actively infected during pregnancy, and afterwards we want to make sure they're following up accordingly with their specific primary care specialist, whether it be the pediatrician or for the mother, their primary care physician, or if they need to be referred, they can.
Helpful. So we talked about, I think in previous sessions, how it is important to counsel on, and then of course you highlighted it here. So when you are doing that counseling, and when you're testing the individual that's pregnant, when do you typically want to test that person? I've heard some people are testing it closer to the end of pregnancy. I heard one hospital, I think, is doing it right at birth. Or is it really advised to do it maybe earlier in the pregnancy?
Are we talking about, wait a minute, rephrase that question, Mia.
Sorry, testing for hepatitis C. When do you think you'd want to do that within the pregnancy?
I would say it wouldn't matter. I might get Dr. Chastain's expert opinion on this. I would say, based on when I see patients being screened in the OB clinic, they're usually screening them around the beginning of the second trimester. Not sure if that's a hard and fast rule. That's probably just when they're following up for their OB clinic appointments from that standpoint. But I would say if you see a viral load, that would definitely prompt us to want to make sure we add them into kind of a watch to make sure we're monitoring that patient, make them aware of the diagnosis, and then make sure we follow up after they have delivered to make sure we get them into treatment accordingly afterwards.
And just to add on to what Dr. Allen mentioned, I think that when it comes to testing for hepatitis C during pregnancy, I think the answer is usually yes, regardless of timing of pregnancy. The goal is to evaluate a woman or a person who's pregnant during that initial evaluation where possible, as far as standard baseline laboratory test. If that testing is negative and there's no interval risk factors between that time and subsequent care during that pregnancy, repeat screening may not be indicated. However, people who present initially are screened, do not have evidence of hepatitis C, but have ongoing interval risk factors, then repeat screening may be conducted in the third trimester, similarly to HIV testing. The reality is that people who are pregnant may present at any point during their pregnancy, whether it be for routine evaluation early after pregnancy is confirmed, whether it be midway, second, third trimester, or even just at the time of birth with no prior prenatal care. And so in that context, hepatitis C screening really should be obtained as early as possible so most appropriate evaluation, counseling, and engagement in care can be conducted. Ultimately, though, how that's executed on each individual patient may be a little bit different.
That makes sense. And good point that it could be that they're presenting at varied times. A couple of questions that showed up in the chat. Someone asked whether breastfeeding is considered safe. I'm assuming that means if a person has hepatitis C. And so Dr. Alfaro Cruz jumped in and said, yes, it is. And then the comment was made as long as there's. Go ahead, Dr. Alfaro Cruz.
Yes. So yes, it's safe to do breastfeed, but you have to make sure that there's no, I think someone else commented about making sure that the nipples are not cracked or there's no bleeding. And so, yes, that would be the exception. But we always recommend that you can switch to the other breast while the breast that has the bleeding or the cracks, it's healing. But it's not a contraindication for breastfeeding.
And does that change if the person's on medication? They can breastfeed while taking medicine if they're in that postpartum period and be treated for hepatitis C? Is there any comments on that?
Sorry, can you repeat that?
What if a person is being treated for hepatitis C? Is breastfeeding safe during treatment?
Well, I don't, so far as to what I know, it would be safe. And it would not be contraindicated for that mom to continue breastfeed. I don't recall, and maybe Dr. Allen can recall what's the breastfeeding category, because I don't have it on top of my mind. I don't know if it's a B or a C, where you evaluate it, whether it's actually the risk outweighs the benefits outweighs the risk. But it's not. We have had some moms that are continuing breastfeeding and they're taking the medication.
Yeah, I don't think I have it off the top of my head. I can try to look it up.
I think
Just-
a couple of things when it comes to this question, though, just to echo the other subject matter experts, is that the amount of hepatitis C medication that is exposed through breastfeeding is relatively low as far as the volumes, at being around 1% as far as what might be achieved, like in serum levels or through traditional administration. So in that context, this is a very low medication exposure to an infant who is breastfeeding to the medication. And we also recognize that the majority of, with both glycaproproprid, mevret, or sofosbuvir, trinitabaclusa, that those are medications that may be used in the context of pediatric care, although they are currently approved for age 3 and above. There's no evidence that they are harmful at younger ages. So in that context, I will routinely tell people that this is something that should be discussed between the person who's breastfeeding the infant as well as a physician about risks and benefits. I generally tell patients who I care for is that we don't have any evidence that medication is harmful to infants. In fact, these medications are approved for use in children age 3 and above. The amount of medication exposure is very, very small. And so ultimately, after presenting that information to folks, we generally often end up deciding together in shared decision-making to continue hepatitis C treatment in that context.
Dr. Chastain. So another question I see from Jonathan Johnson. I have seen some publications regarding co-administering HIV and hepatitis C treatment via the simplified treatment guidelines. Do you think that HIV will remain a contraindication for simplified treatment, or are modern regimens decreasing that barrier?
I got this one. So this is a very interesting context. And I think that, Jonathan, you picked up on something that I think is really important, is that while HIV is listed as a population that doesn't get covered or is quote unquote not appropriate for the simplified guidance, there is effectively no difference in managing a person with HIV who has hepatitis C as compared to the general population. There are very nuanced changes as far as specific medications other than those that are in the simplified guidance as far as durations of therapy and eligibility for therapy, but has actually no bearing on glycaproproprid or sofosbuvir. What this really is a holdover from an era where treating people with HIV and hepatitis C was different than treating people with hepatitis C alone. What is different, and I think it's going to be illustrated in our case presentation, is that the attention to drug-drug interactions is incredibly important. There is a statement in the simplified guidance that we should address drug-drug interactions and evaluate people, but it's doubly important in people who are being treated for HIV. Outside of a very intensive drug-drug interaction assessment, ultimately, the care for a person who's treatment naive without cirrhosis or treatment naive with compensated cirrhosis, whether they have HIV or not, really isn't any different. So while they still remain a population that is in the top part of an exclusion for the simplified guidance, really the only difference in clinical practice is really intensive and focused drug